Relevance of polyp size for primary endoscopic full-thickness resection of suspected T1 colorectal cancers. Introduction. The introduction of National Colorectal Cancer (CRC) screening programs has resulted in a rising incidence of early submucosal invasive cancers, T1 CRC. The risk of lymph node metastasis is low, especially for those cases without histological risk factors, such as lymphovascular invasion, tumor budding, and poor differentiation. Because of this low risk of cancer recurrence after local excision, an organ-preserving strategy is recommended. Currently, polyps with the potential risk of submucosal invasion are selected for a local en bloc excision based on their optical features such as non-granularity, depression, left-sided location, and easy friability. When endoscopically optical signs of deep submucosal invasion are present, primary oncological segmental resection is advocated. However, recent reports have provided evidence that the risk of an adverse outcome for deep submucosal invasive T1 CRC without other histological risk factors is only 1.5% to 2.5%, which is lower than the cumulative mortality and recurrence rates after oncological segmental resection. This legitimizes the strategy of a local excision first as a final staging procedure, followed by completion surgery in patients with a high risk of adverse oncological outcome. As local excision could potentially be curative, an R0 resection should be the aim. Endoscopic submucosal dissection, ESD, is currently accepted as an en bloc endoscopic resection technique for the removal of T1 CRCs. However, because of the dissection through the submucosa, this technique seems limited to T1 CRCs with superficial submucosal invasion. With 65% to 70% of T1 CRCs being deeply invasive, additional treatment techniques providing a radical endoscopic resection with free margins in the colon are needed for this group. Endoscopic full-thickness resection, EFTR, is a relatively new, minimally invasive endoscopic resection technique using clip-assisted removal of polyps with the advantage of facilitating a transmural resection. EFTR may therefore provide very good control of the deep resection margin, especially in the case of deep submucosal invasion. A large German case series of EFTR procedures for mainly benign indications demonstrated an overall histological R0 rate of 77.7%. However, the R0 resection rate was inversely correlated with the size of the polyp, showing a significant decrease to 58.1% for polyps larger than 20 millimeters. Limited data suggests that EFTR also has the potential to facilitate an en bloc R0 resection for malignant colorectal polyps. The same group reported an R0 resection rate of 60.9% in 92 EFTRs for colon cancers with a median lesion size of 20 millimeters, while a Dutch registry demonstrated a higher R0 rate of 77.9% in 71 EFTRs for suspected T1 CRC with a median size of 13 millimeters. It appears EFTR may be very successful in achieving an R0 resection, but it may also have an upper size limit. The authors therefore studied the effect of lesion size on the R0 resection rate, with EFTR as the primary treatment of polyps suspected of being T1 CRC. Methods. EFTR procedures for suspected T1 CRCs performed between 2015 and 2021 were selected from the endoscopy databases of 3 tertiary centers. The main outcome was R0 resection, defined as tumor and dysplasia-free margins for both the deep and lateral resection margins. Regression analysis was performed to identify risk factors for R1-Rx resection, mainly focusing on endoscopically estimated polyp size. Results. 136 patients underwent EFTR for suspected T1 CRC. Median size 15 millimeters, 83.1% cancer. The rates of technical success and R0 resection were 87.5% and 79.7% respectively. Increasing polyp size was significantly associated with R1-Rx resection with a risk ratio of 2.35 per 5 millimeter increase. The R0 rate was 89.9% for polyps 15 millimeters or smaller, 71.4% for 16 to 20 millimeters, and 11.1% for those larger than 20 millimeters. Conclusions. EFTR is associated with a 90% R0 rate for T1 CRCs of 15 millimeters or smaller. Performing EFTR for polyps 16 to 20 millimeters should depend on access, their mobility, and the availability of alternative resection techniques. EFTR for polyps larger than 20 millimeters results in a high R1 rate and should not be recommended.